Good afternoon, and welcome to our 8th session in our first virtual Successful Aging Expo. Today's session will be very interesting. It's entitled Avoiding Joint Replacement. My name is Al Manzi. I'm the president and CEO for Prairie Mountain Media. I'm also the publisher for the Longmont Times Call. Before we start, if you take a look at the bottom of your screen, you'll see a Q&A box and a chat box. That'll give you an opportunity to ask questions anytime during the presentation. We won't answer those questions until after the presentation, but shortly after the presentation, I'll ask the questions that came in from the audience first. Then I might add a few. Today's presenter is Dr. Jason Markle. He is a physician at Centeno-Schultz Clinic. So please join me in welcoming Dr. Jason Markle.
Alrighty. Thanks for the introduction, Al. As Al stated, we'll be talking about things we can do now to avoid joint replacement. So, Al, how's the video looking?
That looks great.
Perfect. All right, so one of the things we're going to be talking about is just innovations in orthopedic medicine and what sort of changed in the last probably 15 to 20 years to help patients avoid things like knee replacements or more invasive orthopedic surgeries. So a little bit about myself. As Al said, I'm a physician at Centeno-Schultz Clinic. My background is a PM&R, physical medicine rehabilitation physician. I then specialized in a fellowship called Interventional Orthopedic, actually here at the Centeno-Schultz Clinic about 5 or 6 years ago. And then I've been working and practicing here at Centeno-Schultz Clinic, where we are 100% focused on a term called orthobiologics, meaning stem cells, platelet-rich plasma. And this is the headquarters of a huge physician network group called Regenexx. Regenexx is physicians around the world that sort of have this same mindset of how to treat patients. And we all have some proprietary how we process samples and makeup. So we're sort of like the headquarters there. I'm also a course instructor, member of an Interventional Orthobiologics Foundation, which is a nonprofit organization, which really advocates for education, teaching physicians around the country and the world how to really do these treatments properly. So as well as I'm basically an author where I publish lots of publications on this type of field, the use of orthopedic orthobiologics for stem cells, PRP for different orthopedic issues, whether it be your spine or joint issues. So first, if we're going to redefine orthopedics, let's talk about their traditional, what orthopedic medicine typically is. Typically, you have some sort of injury or onset of pain. You eventually come to see one of us. Typically, the mainstay of most orthopedic conditions is physical therapy. And as a physiatrist, I think physical therapy is an excellent opportunity to really work on your biomechanics of the joint to really help patients get stronger and a little bit more functional. But if that really doesn't do it, then the next is throwing medications at it. A lot of anti-inflammatories, ibuprofen, Mobic, Aleve, Celebrex is a big one. And these medications sometimes can help. Long-term wise, there's also downstreams, but hey, they can damage your kidneys, damage your liver. So there's, after that, a lot of times they try injections. If we're talking about knee arthritis, typical injections are going to be hyaluronic acid or lubricant, or a corticosteroid, a steroid injection. If you look at research long-term wise, steroid injections aren't the best for most tendon, ligaments, orthopedic conditions. They can help short-term wise, but now over probably the last 10 years, a lot of research has come out to showing actually steroids are toxic to things like tenocytes, meaning tendon cells, as well as cartilage or chondrocytes, and that can actually advance arthritis long-term wise. And ultimately, you end up at the surgical options at a surgeon's office when they start talking about more invasive things, such as joint replacements, reconstructions, or whatnot. So the idea of changing this paradigm over the last probably 15 and 20 years has been really more in the forefront of medicine. And things we can do that are the advent of things like platelet-rich plasma and stem cells. If we think about research and longevity, this isn't a new concept. This is something that it's introduced probably almost 100 years ago is there something we can inject into somebody to sort of accelerate someone's healing mechanism? That was termed prolotherapy in the 1930s, 1950s. And then eventually we actually discovered stem cells for orthopedic stem cell called mesenchymal stem cells. Those are the stem cells in your body that actually becomes tendons, joints, muscle, cartilage. And then in the 1990s, an orthopedic surgeon out of France, his name is Dr. Herniation, he started really researching this and using a concentration of your bone marrow, which houses all your stem cells, to treat orthopedic conditions. And he started publishing. Now we've got 30-year outcome data on some of his early treatments, which is great. And then in early 2000s, Dr. Centeno and Dr. Schultz really started adapting that and using that in the United States. And we were actually the originators of using stem cells and PRP to treat orthopedic conditions here in the United States. And we've been continuing that trend in publishing and researching since then, and we continue to get better and improve our outcomes and treatment for different orthopedic issues. We can see on the right-hand side here, all the research that's been done over the last probably 10 years, it's dramatically increased, which is great. So we have more research, more data, and we actually know, well, what works for what and how does it work. So now I use the term orthobiologics. So what do I mean by orthobiologics? So ortho meaning bones, cartilage, tendons, ligaments, and biologics are essentially substances that we can harvest from yourself or outside the body, such as dextrose or something that stimulates your body's repair mechanism. Now, if we look at orthobiologics, there's multiple types out there to know about. One is called a conditioned media or exosomes. The one is extracellular matrix, meaning xenografts, demineralized bone matrix, as well as a popular one these days is called birth tissue, or amniotic membranes, or amniotic fluid, or some sort of amnio product. Now, something to be aware of, that these first two conditions, the conditioned media, exosomes, as well as the birth tissues, right now there's very little research on these to actually say, one, it's effective, but more importantly, it's safe. So if have been considering like a stem cell injection, there's a lot of clinics that actually offer these injections, but the problem with it, the FDA, as well as us, we agree that they're not safe. There's not a whole lot of research behind them. So getting these injections into joints, tendons, ligaments, we don't know if they work, and as well as we don't know if they're safe. So just be aware of that. Really the thing that most physicians are going to use are these last two. We term these autologous, meaning they're coming from you, going back into you. So there's things you can enhance your body's healing mechanism. One is through blood products or platelet-rich plasma, and the other are stem cell containing products, and there's two different sources of stem cells. The most rich one is coming from your bone marrow. There's also some stem cells in your adipose tissue that we're finding work well for things like knee arthritis. So things we treat with these products, sort of the full gamut from a spine joint conditions, whether it be neck pain, headaches, back pain, joint pain, tendons, ligaments, anything orthopedic related, we sort of treat them all. But today we're going to be focusing on more knee conditions such as arthritis. One of the most common questions I get, especially from patients coming in for an evaluation, is, well, what does the research show? Insurance doesn't cover it, so that means there must not be a whole lot of research. It's actually quite the opposite. So if we look at research, Dr. Centeno put this slide together, just looking at platelet-rich plasma, blood platelets, compared to different modalities to treat knee arthritis. Randomized controlled trials are probably the most mainstay treatment of the show a treatment works. And these are all the randomized controlled trials that have been done utilizing platelet-rich plasma comparison to our standard of care, such as steroids or hyaluronic acid, as well as multiple other modalities. And the good news is the vast majority of them are all showing positive outcomes. And then another question we typically get is, what can PRP really do for my cartilage? Can it regrow cartilage? Can it protect your cartilage? And how does it work? So with any kind of research or translational medicine, it always starts in the laboratory, looking at animal research, and then eventually working its way into human trials and human research. So let's take a look at some of the early animal studies. So if we just look at a rabbit, does PRP protect or help your cartilage in a rabbit model? And we found that yes, PRP is very helpful in protecting the joints from arthritis. They do that by reducing a lot of inflammation and preserving and protecting your cartilage by reducing that inflammation. And if we go on to another one, let's look at maybe a rat model. In arthritis also is the degeneration of your cartilage. So the cells that make up your cartilage eventually die. And they were able to show that PRP actually helps reverse that. It actually protects your stem cells in your cartilage from breaking down and dying. So it's not only an anti-inflammatory, it also is a cartilage protected. Then last, let's look at a goat model. Does PRP or using the concentration of stem cells protect from a goat model? And lo and behold, yes, it protects your cartilage and preserves the cartilage. Stem cells tended to work a little bit better than PRP, but both work very well. And lastly, then eventually we went on to a human model. So now looking at MRI before and after from a cartilage standpoint, we can see that, well, almost 3 out of every 4 patients all showed no progression of arthritis. If we treated someone with arthritis, treated them with PRP, over time we saw, even over years, that those patients that were treated with the platelet-rich plasma really had preservation of the cartilage. It didn't advance the cartilage, it helped protect the cartilage you do have and keeps it healthy. And now the ultimate question is, well, what about having a joint replacement? I already have pretty bad arthritis. Can it sort of stop that progression or maybe even delay the need for a knee replacement? And luckily, there's been research on that as well. This actually came out in July of 2020, so not too long ago. And they looked at, well, platelet-rich plasma injections as it pertains to, well, does it really prevent you from having a joint replacement? And this one looked at almost 700 patients. And ultimately, about 75% of the patients delayed a knee replacement on average about 5.3 years. As well as 85% of them eventually didn't undergo a replacement at the 5-year follow-up. So over a 5-year period, we've been able to prevent and delay the need for a knee replacement. Doesn't make the knee perfect, but ideally it helps pain as well as function. And those are the 2 big things that sort of limit patients, as well as indicate if you can't do what you want to do. And if the pain is so severe, that's when the orthopedic surgeon says, well, come to me when the pain's so severe that you can't do anything. That's the indication to actually have the joint replaced. So there's a lot of research out there, as I've shown throughout these last slides, that we know how it works. We know what it works for. So there's a good option for patients that have failed all other treatments, such as the therapy, the physical, any kind of injections. Like if you've had steroids, if you had the hyaluronic acid, a lot of times this modality works a lot better and can keep you pretty functional. So next, let's talk about the actual stem cells. How much research out there is on stem cells? Well, as I initially showed on that slide, over the last 10 years, there's been a huge uptick on the amount of research really focused on utilizing stem cells, and the most common source is your bone marrow stem cells. And all these yellow dots on that screen are actually things we've published. And we actually publish probably almost half of the amount of patients out there. So we published quite a great deal on stem cells use for different orthopedic issues. But if we're just talking about a joint replacement, as I mentioned earlier, Dr. Hernigow, he just published this in April of this year, where over the last 15 years, he's shown that utilizing stem cells can actually delay the need for knee replacement up to 15 years. So, well, platelet-rich plasma can really, short-term, maybe 3 to 5 years, stem cells tends to work better, delaying the need for a knee replacement up to 15 years, which is excellent because we look at joint replacement in general, typically they last 10 to 15 years. So if we can delay the need for one joint replacement, and maybe you just need one joint replacement in your lifetime, that puts you at less risk for complications, such as the problem with knee replacements, things that can kill you, unfortunately, infections, blood clots, heart attacks, strokes. These are all pretty significant complications of having a big knee operation like a knee replacement. So that's the beauty of utilizing stem cell therapy for different orthopedic conditions, where we can delay, if not prevent, the need for a lot of these orthopedic issues. As we saw, 4 out of 5 patients, up to 15 years. So with the advent of new technologies such as platelet-rich plasma, bone marrow construct treatments, also breeds a need for precision injection. So a lot of people that inject steroids or hyaluronic acid, there's only one different type of injection they can do. But with the advent of different technologies, we really need to pinpoint exactly where we put the stem cells or PRP. So we've actually termed it interventional orthopedics, where we are training at a higher level, where we're able to use usually live x-ray or some sort of image modality or at musculoskeletal ultrasound. So we can precisely guide the needle into where the damage is, so we can inject directly into it, because close isn't really good enough for stem cells or PRP. You need to be pretty pinpoint in exactly where you put it, whether it be the knee joint, a tendon, or ligament. So that's a huge thing. And that's why just using the stem cell injection really needs to be paired with precision image guidance. An example of this, we treat a lot of ACL injuries. So an ACL tear, we can precisely inject directly into an ACL, and this is a live x-ray image where you can see the black stuff is the contrast, and we're getting directly into the ACL. And that's huge, because before this, a lot of people were injecting blindly, meaning feeling and poking. They sort of feel where the joint is and just throw the needle in and hope and wish it gets where it needs to go. And we've also published on ACL injuries, such as like ACL tears, that we see about 70–80% of them do extremely well. And this is another publication, and we have before and after MRIs, where we can see torn ACLs. 6 months later, we can actually see the ACL itself is almost like a brand new ACL, and the radiologist actually calls this a normal ACL. So not only do we precisely inject it, well, we can prove like, okay, we're initiating the body's healing response to getting soft tissue to really repair itself. As well, and here's another before and after of an ACL. And we have to do this over and over again. We've published on probably 60–70 patients at this point that have these good results. And then we also did a randomized controlled trial ourselves. So we randomized it and then controlled it. And eventually we are still seeing about the 70–80% mark, really improving from a pain and function, as well as seeing healing on the MRI. And then if we talk about like rotator cuff tears as well, we've done research on that, and looking at before and after MRIs, we can also see that, okay, if someone has a big tear in their rotator cuff, this is where we can actually repair that. And we've been about 89% successful so far. And the research goes on and on. We can sort of apply this not only to arthritic conditions such as knee arthritis to help you prevent the need for a joint replacement, but a lot of people have sciatica, and traditional mainstay of that is corticosteroid epidurals. We've replaced that with a simple platelet procedure where we use a platelet combination, platelet lysate, which is a formulation of platelet-rich plasma, instead of steroids as an epidural. And we've got more longer-term benefit from that, as well as like a disc herniation. I've published on this where we can inject stem cells directly into a disc herniation and get that to sort of regress as well. And we're fortunate because we've been doing this for about 10–15 years. We see patients sort of from all over the states. We also are even more fortunate where patients fly from all over the world to come to our clinic, because like I mentioned earlier, we're some of the originators of the platelet-rich plasma and stem cells. So people want sort of like the best, as well as they want the most efficacy. We're continuously getting better and continuously modifying the things we do. So a lot of patients come to me and ask, well, what should I really look for in a physician that's really going to treat me with one of these modalities, such as PRP or stem cells? So when you're evaluating a physician, if they're right fit for yourself, there's three big things you need. One, you should be a physician. Unfortunately, there's a lot of bad players in this game because it's a newer science. So a lot of people are somewhat taking advantage of it. Even like chiropractors are injecting those amniotic products, and really chiropractor isn't trained in how to do these injections. So it really should be done by a physician, especially a physician with an orthopedic background such as PM&R, sports medicine trained, or even an orthopedic surgeon. And then training. A lot of the training for these type of injections aren't really taught in traditional residency. So when I was going through 4 or 5 years of residency training, they never really showed me how to do these injections until I did a fellowship directly into this. And we have our nonprofit organization, the Interventional Orthobiologics Foundation, where we can actually certify physicians who come and get properly trained on how to really do this properly. And then image guidance is huge. You don't want someone, you don't drive at night with the lights off. So if someone's driving a needle in you, you want to make sure you know where you're going. So image guidance is the utmost importance versus a physician just feeling poking. You really want them to know exactly where everything's going. So as I mentioned, we're at Centeno-Schultz Clinic. You can find us on social media as well as contact us directly. We're always happy to discuss about any orthopedic conditions. We do a lot of telemedicine visits these days. So a lot of people from out of state, out of the country, or even from across the city that doesn't want to come into the clinic just because of obviously COVID right now. Everyone's really hyper vigilant on safety protocols, and we also have a lot of those in place. So feel free to reach out to us. And then we'll open up the questions now.
Dr. Markle, that was outstanding. Lots of new information there for all of us. We've got one question here. It is, okay. So I was going to ask this question too. Can you tell us the cost of the processes? So what is the cost of a stem cell procedure and a platelet-rich plasma procedure?
Absolutely. So unfortunately, a lot of these, oh, can you hear me?
Yeah.
Oh, perfect. It was getting a little echo. But a lot of these different modalities, unfortunately, aren't covered by insurance. So yeah, it's going to have an out-of-pocket expense related to it. If you're talking about platelet-rich plasma, ballparks on average anywhere from $1,000 to maybe $2,000 to $3,000. And then stem cells can go up from probably $4,000 to $5,000 up to maybe $7,000 to $8,000.
And they've come down quite a bit through the years, because I remember when I was looking at them many years ago when it was still illegal.
Yep.
That they were $10,000 to $15,000 back then.
It has, yep. As technology advances, we're able to be a little bit more efficient with our technology, so it's not as costly, so our overhead isn't as much.
What is the recuperation time from a PRP procedure?
So depending on what we're treating, if we're treating a knee joint, that's usually about 6 to 12 weeks. Acute downtime is typically about 72 hours. The first phase of healing is an inflammatory phase. So right after the injection, we expect everything to swell up for usually the first 72 hours. And then it sort of calms down, and that tissue continues to mature over the first probably couple months. So usually symptoms get better, usually around that 6 to 12 week point.
Here's another question. Do you do the adipose tissue procedure? And what do you think of it?
I do. So microfragmented adipose tissue. We do that on some patients right now from a research standpoint. Most of the research is showing that MFAT, or the microfragmented adipose tissue, we'll just call it MFAT. That's really good for knee arthritis, very similar to stem cells from your bone marrow. It hasn't really been studied outside of just arthritic conditions. So if someone has bad arthritis, sometimes we'll harvest both sources. We'll do your adipose as well as your bone marrow and put them both together to give patient the best potential outcome.
And the question, follow-up question on that, is that FDA approved right now?
Yeah, so FDA approval. So FDA controls is a Federal Drug Administration. So they really control drugs. If we look at the FDA itself, this is considered in their eyes a medical procedure, a same-day medical procedure. So it's not a drug, it's a medical procedure. So it's FDA compliant, but it doesn't need FDA approval. There's another stem cell injection we used to do here in the States, but we actually have an offshore account called the culture expanded stem cells. So if we take your stem cells, we can isolate the stem cell out of your bone marrow, put it in the petri dish, and we have cell biologists that can actually make that stem cell grow to a bigger number. The FDA regulates that process. It's called a culture expanding process, as you're creating a biologic drug by expanding them outside your body. So that process needs to be FDA regulated. We have a licensed clinic outside in Grand Cayman that's allowed that procedure. So we do that specialized stem cell injection here. If we wanted to do it here in the States, unfortunately, we'd have to go through the full FDA trials, and that's about $500 million, and we're a little short. So everything we do is FDA compliant. We actually initially started stem cell injections with a culture expanded treatment back in 04, 05. And then the FDA, we're the only people doing it. FDA came into our clinic, saw what we were doing, eventually said, well, you need full approval. So we work with them to figure out, well, what's the best thing we can do without going through the FDA? And this is sort of like what we've come up with.
Thank you. What's the latest with regard to the foot? Hallux rigidus and Cartiva seem to be failing.
Yeah, so Hallux rigidus is basically a arthritic condition of your first big toe, where it becomes so arthritic where the bone spurs prevent it from really extending. So that's something that we can do a small decompression around with the bone spurs. So if we can, on ultrasound, if we see big bone spurs sort of hitting each other, usually they're pretty small. There's a procedure called a Tenex, T-E-N-E-X, where we can sort of take down those osteophytes with a small percutaneous injection, shaves down the bone spur, and then we put some platelet-rich plasma in there. When the bone spur gone, allows the range of motion now, and then PRP or stem cells really helps the arthritic condition, stops it from coming back. So there's definitely things we can do for that. Yeah.
Thank you. How well are the injections, PRP or stem cell, working for hip joints?
Yeah, hip joints are very tough. If you get more in that mild to moderate phases, so early on from arthritic condition, PRP and stem cells work extremely well. Once we get into that severe range, PRP does not work very well, and even stem cells that are same-day bone marrow is probably less than 50% of the time. Versus like knee arthritis, it's the exact opposite. Even severe cases, you can treat that with stem cells, and as I mentioned earlier, get about 15 years of benefit. And we're still ongoing in ways that we sort of make that better and trying to figure out why that is. So that's some research is really pretty much ongoing still.
Excellent, thank you. Can PRP be used to treat foot neuropathy? That's a really common problem associated with back and disc issues.
Correct. So if the nerve problem is coming from your spine, typically yes. We can use, and as I mentioned earlier, I did some publications on using PRP or platelet lysate epidurals to help nerves regenerate and repair to prevent the sciatica. If someone has like bad diabetics, it's more of like a metabolic issue where it's damaging their nerves. That's more of a systemic issue, and that's something just working with your primary care doctor and really getting your blood sugars under control, your health, or your overall health status. That'll help that condition versus the platelets probably won't help as much.
So what you're saying is that if you have a compression of the sciatic nerve and it causes some numbness, some level of numbness in the foot, that there's an opportunity for either PRP or stem cells to potentially regenerate that nerve, because if it's dead for years, how does it regenerate?
Yeah, so if the nerve itself is getting irritated or compression of a nerve, someone has a foot drop. They'll have actually motor function loss. That's a true compression of a nerve. But if the nerve just gets chronically irritated, the insulation on the outside of the nerve gets worn down. It's called the myelin. And then you have gaps in your myelin, and that creates the numbness and tingling in the leg. The platelets are actually help to remyelinate nerves. So the growth factors and all these growth factors, when we put it around the nerves, it helps repairing the nerves quite well. There's lots of studies on like carpal tunnel syndrome in your wrist, utilizing PRP, where someone even has weakness in the muscles of the hand because of the compression. They just put PRP around the nerve. It helps that strengthen the muscle itself. So neurologically and electrophysiologically actually improves. So the PRP works extremely well around nerves. Stem cells, not so much. So you don't want to put the bone marrow stem cells or the adipose stem cells around your nerves. You only want to put platelets.
Interesting. So I'm sure you always get this question. How painful are the treatment options?
Yeah, it depends what we have to do. One of the things researching, there's certain anesthetics that are actually toxic to stem cells. So like Markane, lidocaine, some common anesthetics that most orthopedics use, they're actually pretty toxic to your own stem cells. So sometimes if we're using a stem cell injection, we'll use some sedation, so some conscious sedation to help the pain for the injections itself. And usually we're able to get them through the procedure without any complications. Spine procedures are more platelet-based therapies. So those are something we typically don't need sedation, or any PRP conditions or treatments. Typically we don't need sedation. We can use a little bit of anesthetic with it. So they're needle pokes, they don't tickle, but we're able to minimize how many needles with the image guidance. So I know exactly where the needle's going, so I don't have to stick someone 50 million times. So we can definitely make you comfortable no matter what.
Excellent, thank you. A few other questions. You had mentioned that there's no progress of arthritis. How long, and then how many treatments are typically necessary with PRP or stem cells to achieve what you were describing, where you had long-term, more than 5 years results with your treatments?
Yeah, so the PRP treatments that we mentioned earlier from a research standpoint, that was a single injection. They've see if they can maximize it with multiple injections right away. It really didn't change too much of the outcome from a platelet procedure. And again, that's usually that 1 to 3 years. So from an overall maintenance therapy, typically I recommend maybe 1 PRP injection every year or 2, just to maintain cartilage. Like my own joints myself, I get platelet injections probably once a year, just to keep my spine healthy, my joints. I've had some arthritis in my wrist from a prior surgery. So I get that treated probably once a year, and it keeps me pretty active and pretty healthy. Stem cell injections, probably maybe 1 every 5 to 10 years.
I've had doctor friends who have said that, people that suffer from degenerative disc disease or pretty, mild to moderate arthritis in the back, particularly the lumbar region, that the stem cells have not proven, or PRPs haven't proven to be that effective. Is that just bad information, or is that just not understanding what's really happening in the industry now?
Yeah, that's probably just misinformation, or maybe we initially thought like degenerative disc disease, where your discs sort of pancakes.
Mm-hmm.
Stem cells does not help that. PRP doesn't. You can't inject the disc to sort of plump it up. If you're a mouse or a rabbit, it works extremely well for. But in a human, it doesn't really work. But if we're talking about pain as well as function of a spine, usually you inject the facet joints, which is essentially a small knee joint, a synovial joint. PRP works extremely well for that. As well as if a disc is bulged or torn, you can inject stem cells or PRP directly into the disc to help the disc tear itself heal if it is creating pain. So degenerative discs, what you had mentioned is absolutely true, where usually stem cells or PRP can't regenerate a degenerated disc. But if we're talking about what's causing the pain of that degenerated disc, it's typically not the disc, it's usually everything around it. You lose a little bit of disc height, it shortens some ligaments around your spine, puts more pressure on the nerve, also more pressure on the facet joints, So when we're treating someone with degenerative disc, we typically use more of like a platelet procedure, and we're treating sort of like the functional spine unit. We treat some ligaments, we treat around the nerve, as well as into the facet joints. And that tends to, we have continuous outcome measures, and that shows that's continuously successful in preventing patients for like fusions or disc replacements or things along those lines. We've had a pretty good track record at that.
Excellent, thank you. You were talking about ACLs. Are you referring to complete tears of the ACL or partial tears of the ACL that are being repaired at that level?
Both. So there's three different types of ACL tears. There's a partial, there is a complete, and then there's a complete retracted tear. So even if the ACL itself are fibers that go this way, if it's completely torn, but it's still approximated, meaning the sheath that keeps all the fibers together are still aligned, and that's probably 60 to 70% of ACL tears are complete non-retracted, where everything is still there. So it's just sort of like disorganized. Well, if it's still there, it gives us some tissue to work with. So we can inject that tissue and get that to heal properly, versus if it's completely torn and retracted and then it's just floating in the wind. That's something that needs surgery.
So why do athletes then always choose for surgery rather than this type of repair? Is it a longer term repair and multiple injections, or is it like you were describing before, where it's basically one?
Yeah, it's a single injection, but with athletes, it's a different breed. The chance of them doing a single procedure and getting back to their job, essentially, a lot of athletes will elect for surgery because it's more well known. We're the only clinic that really does this at a high level, so not many athletes elect to do this just because they look at their long-term financial. Can I go back to work? If they do this procedure, they get back to training, they re-tear it, then they have to go through the reconstruction. That takes another year. So that's 2 years out versus just having the reconstruction and going back to the sport. So typically it's more of a timeline thing as well as a risk. We've had a lot of patients at this point, recreational athletes, tear their ACLs and get them back to their sport within 3 to 6 months. But professional athletes, it's a whole nother ballgame on their end.
And so, is there a timeline from when the ACL tear occurs to when you could still repair it?
There's not. It's all about how it looks. So we typically want to MRI as close as we can to treatment to make sure we know exactly what we're dealing with. And even if it's still 5 years old, if it's non-retracted, it's still there. So it gives us something to treat.
Are patients arthritis patients that are getting treatments with PRP or stem cells, are they seeing an elimination of their anti-inflammatory drugs like meloxicam or any of those?
Correct. A lot of our patients, one, we don't want them on those drugs long-term wise because, one, they're not good for you, and two, there's some probably healthier alternatives, such as like turmeric, fish oil, bromelain, glucosamine, chondroitin. The combination of those, actually, there's a lot of research out there that shows it actually works better than those, and they have a better safety profile. A lot of patients, eventually get off all those drugs altogether, and then sometimes start some other supplementations and keep them pretty healthy.
Excellent. Let me see here. Do we have another one? I think you already talked about this, but PRP and stem cells are not covered by Medicare or other health insurance programs.
Correct.
So they're
we do have like Regenexx as a whole. We have a self-insuring network since we've been doing this for about 15 years. Every patient we've ever treated has enrolled in a registry, so we can follow their outcomes and data over the last 15 years of every patient we've treated. So there's a lot of patients, companies that do their own self-insuring, and they've actually covered the Regenexx procedures because we have so much data. And once they cover our procedures, we've actually reduced their orthopedic expenditure from insurance costs. So we've prevented knee replacements, we've prevented those, so we've actually saved them hundreds of thousands of dollars. So we've got about a couple million covered lives right now throughout the states. And that's just building. We're getting bigger and bigger accounts essentially. So as that grows, eventually other companies such as Medicare, Medicaid will understand the use and the advantages to covering this. So we're continuously working on that and trying to build those bridges.
And, I mean, as a consumer, if I try this procedure on my knee and I don't get results, do you have like a secondary injection, or is it another full charge? How does that work?
Yeah, so typically, and that's why having a good evaluation, after we evaluate you, get you all the information, we'll give you what we call a candidacy. It's like based off your specific injury or condition, how well do you situate for these treatments? Are you a good candidate, meaning all the research shows, hey, we've got a high probability of success? Or are you like a poor candidate, like, hey, this is probably not going to be the best thing for you. We can try it, but you may want to look at alternative options. So we have a pretty honest evaluation. We spend about an hour with you from an evaluation standpoint, just to sort of get the best understanding of your goals, as well as how we feel we can help. So, and if we don't, let's say if we have a treatment, we've got different sort of like programs available called proactive. This sort of will reduce the cost of any subsequent treatments that we need.
So HSA savings accounts cannot be used for cosmetic
They can
non-life-threatening. So that was my question: is HSA accounts can be used for plasma-rich or stem cell injections?
Correct.
That's a big deal. That's a big deal because as more and more people have HSA accounts, being able to use them for this is a big plus.
Oh yeah, it's huge, and we've seen it help our patients dramatically over the last probably 2 or 3 years because of that.
Well, I guarantee you, based upon everything I know, that you will absolutely get more interest and more calls from this presentation, because it was very interesting and very informative, and you brought us up to date on a lot of new ideas and things that are actually studied and working now, with the somewhat mysterious still stem cell and PRP injections. So we thank you so much for your presentation today, and we wish everyone a good afternoon moving forward today.